Good morning, everybody. Good morning. I hope you can get used to my accent. My name is Khama Rogo. I work with the World Bank Group, One World Bank. And the organizers imposed me on you to be your MC. Not just today, but tomorrow. I pity you. I'm going to be rough on you. I'm going to make sure that you enjoy, but you also give. Be ready to take. I have some good news for you from Africa yesterday. At 9 p.m., while you're having dinner here, something great happened in Africa. It wasn't Boko Haram. It wasn't Al-Shabaab. It's not in the news. It was the birth of a healthy boy somewhere in the suburbs of Kampala, Uganda. Safe motherhood. It's not in the news, but it was great news. This baby was born to a Ugandan lady whom, for purposes of ease of pronunciation, I'll call her Grace. Grace, this was her third pregnancy. The other two didn't make it. She was 38 weeks. She'd been going to a local antenatal clinic the way WHO would want her to go. So at 38 weeks, in the morning yesterday at 6 a.m., she felt some pain in the lower abdomen. She went to the clinic. To get to that clinic, as she has done every week for the previous 30 weeks, she took some transport. It was a motorcycle. That is a mode of transport in that part of Uganda. She pays $1 to get to the clinic and $1 to come back. She paid, she got there, public clinic. She waited for 3 hours on the queue to be seen. And eventually when she was seen, the nurse there thought that she wasn't really in labor but had urinary tract infection. So she gave her a form to go and get her urine tested. But the hospital, the public hospital lab, couldn't do the test. So she went across the road to a laboratory. They call it an informal laboratory. A test was done. She brought it back. They weren't sure whether there was infection or not, but the nurse gave her a prescription for urinary tract infection. She looked at it. She went to the hospital pharmacy. There was no medicine. So she crossed the road to a private one, unlicensed, and she was given the antibiotics. She went back home on the motorcycle, reached home at 6 p.m. She had left at 6 a.m. just to go for this checkup. And at 6 p.m., she cooked for the family, and at the end of that, went to bed at 10. At midnight, she had more pain, this time more strongly. And the husband told her, maybe you are in labor. So they looked for transport to take her back to the clinic. No transport is available. There's no phone calls to call an ambulance, but there's a neighbor who runs a private taxi. They woke him up, took him on this taxi on that trek to the government clinic where she should deliver. On her way there, the labor apparently was more advanced, ruptured the membranes in the taxi, the back seat, and this driver stopped by the roadside. Luckily, on the opposite side of the road, there was a recently opened maternity home by a retired midwife. This maternity home, this midwife opened it a year ago, but she's been waiting for a license to run it. Her application is still sitting somewhere in the regulatory board. So then when they knocked the door, the midwife was there. This lady went in. She was fully dilated. The baby was coming out, but there was cord, umbilical cord around the neck of the baby, which was strangulating the baby. But being the experienced midwife that she was, she unwound the cord, delivered the baby, and both mother and son are well. That is the good news that I bring you from Africa. But let's walk for a moment on the path of this lady. Because next year in Uganda, there's going to be a demographic health survey sponsored by USAID. I love you, USAID. And this lady may be one of the people who will be questioned for the DHS report. And some interviewers will go to her and will ask her, did you deliver in a hospital? He said, I'm not sure if it was a hospital or not. It was a nursing home. Was it delivery under a skilled attendant? Said, yes, but she told me that her clinic was not licensed. So who took care of you during that delivery? Was it public or private? And she starts asking, public or private? Which part of her care was public and which part of her care was private? The motorcycle was private. The taxi was private. The nurse who gave her the prescription was public. The clinic where the test was done for urine was private. The pharmacy was private. But she doesn't care because she has, for the first time, a live baby. So even as we sit here today, let us ask this question, because a lot of time is being spent globally arguing about public and private and how different they are. But this lady doesn't care. All she knows is that she was taken care of and she has a baby. Welcome to this meeting. The sixth in the series that started small, but is now extremely big, 350 of you. But it's a different kind of health meeting. I am a gynecologist. I am a gynecologist, and I'm used to going to health meetings where the scientists sit inside here, and the doers, the marketeers, sit outside in booths. So people come and deliberate on how many cancer cases they treated, and then they go out there during tea time to talk to the people who make the medicine and make the medicine available. This conference is different because everybody is in here. I've never known why these people can't sit together. The people who think, who manufacture, and the people who provide care. This is the difference that has to take place, and this is what IFC has been trying to put together. Bringing us health people, people who care, who want to make a difference, who start thinking differently. And that's disruptive. It is disruptive because we're in a sector which has been ruled for ages by dogma. The kind of dogma that insists that certain things must be done a different way. The kind of dogma that in my continent created something called the central medical stores. 100 years ago when the British were in Kenya and in India, they found it necessary to create a central medical stores. Why? Because medicine was made abroad and had to come by ship. It took 3-4 months before the medicine arrived. Nowadays, the medicine is manufactured locally, and you don't need to take it from the manufacturer to a medical store, for the store then to transport it to another place. And yet, we've never changed it. There is no area where we spend more money annually reforming in our countries than central medical stores. And if I'm to do anything before I die, I want to fight the central medical stores. Because surely technology can allow us to deliver those things better, faster, directly than going through everybody else. So the middlemen are in there that make these things difficult for us. The question is, are we brave enough to start looking internally at our inefficiencies so that Grace gets the care that she needs and ends up with a live baby every time she's pregnant? So that that lady who is in Bangladesh today with cancer of the cervix can reach a radiotherapist rather than being on a waiting list for 8 months. When in the same city where she lives, there is private radiotherapy facilities that are having working at half the capacity? These are the questions that we have refused to ask of ourselves and of the leaderships that we provide in the healthcare. The opportunity is there today for us to be able to do it. I look at you here, and I've seen some of your cards. I've never been around so many CEOs in this sector. In fact, if I look at the number of cards, part of the rainforest in Congo, Kinshasa must be going down because you're making so many cards. But the useful thing is, what do we get out of this conference? Why must we have it and why must we think differently? I want us to be disruptive because we must be disruptive. It is not because we are doctors or non-doctors, it is because the patients need it. And as we do this, let us ask one question. Are we doing it for ourselves, for our professional egos, or are we doing to make health universally accessible? Because that accessibility starts with Grace, that mother in Uganda. And for so long as we focus doing everything so that we reach her with quality, with affordability, and with the kind of kindness that we want for ourselves, we'll be doing well. Welcome to the conference. And to challenge you, the first challenge this morning is the opening keynote address. That keynote address, have you seen from your own program, is going to be delivered by somebody from a developing country like mine. This person is a well-trained cardiac surgeon. You don't need more dexterity of the finger than when you're operating in somebody's heart to make the heart work and the blood flow. But his fame is not because of dexterity of our fingers. It is because he decided to take that surgical skill into the broader area of delivery. The delivery of that service so that it is not just one patient, but it is millions of patients. And in his short life, he has created groups that now make it possible for people at the same level of Grace in Uganda to get their hearts moving. And in doing so, he has made something else move, the heart and the art of delivering health services. He's been honored many times, and I don't want to go through that because it will take too long. But most important is that he's a disruptive thinker. And it is up to him now to give us a sense on why he has been so disruptive and why we must all be disruptive. But most important, for us to start thinking disruptively ourselves so that by the end of the day, there will be no stone left unturned. The nature of this conference will be that it is you to speak. The people who will come here will be to throw some ideas. It has to be fully participatory. So that success will not be because IFC and the organizers brought you here, but because you came here to share your ideas and you came here to make sure that the rest of the world hears and does what we must do for the world to be a better place. Join me, ladies and gentlemen, in welcoming Professor Devi Shetty from India for the keynote address. Thank you very much.